all know that the heart failure is overall a deep concern globally because it has increased the morbidity, mortality, and put a burden, economic burden globally. A very, very expensive syndrome and life-threatening too is as much as cancer. 5-year mortality is 50%. So we have this interesting data coming up from the European Heart Journal saying that in the Europe it is 12 to 30 per 1,000 person. In America it is 2% prevalence, and prevalence in Asia is 1.3 to 6.7%. And there's a lack of evidence of prevalence in South Africa and South America. Now, there are several things that is important for us. Even for India, we have no proper heart failure surveillance study to talk about incidence and prevalence, which will be relevant to our population. So what we do is we extrapolate the data from the 2% that America has, and we say that it is 8 to 10 million heart failure patients. It is reported like that. In the health world, in Times of India, it was reported, and total burden of heart failure is 40% in India. The heart failure worldwide is epidemic. Prevalence is an incidence. Together, the cases are large number. Every year, burden is increasing. And the reason for that is aging population, one, followed by a great survival due to treatment of acute myocardial infarction, PAMI, and increasing prevalence of risk factors. All together increase the burden, global burden of heart failure, and quality of life is completely compromised. So, as I said, it is epidemic. Prognosis is very high mortality, and hospitalization causes main economic burden. So prevention is a great strategy. There is data that $31 billion spent every year on management of heart failure in America. We don't have Indian data in this respect. And out of that, 60% are spent on recurrent hospitalization. So prevalence of heart failure and preserved ejection fraction is also increasing equally, and mortality and morbidity of preserved ejection fraction and reduced ejection fraction, both are absolutely same, no difference at all. So put a lot of burden. Currently, the incidence in 2020 of the heart failure in America is 16.5%, and by 2040 it will be 20.5%. As the population, obesity and diabetes have a pandemic across the world, India is no behind, and you see a typical gender difference from the age. Between 60 to 79, it's a male preponderance, but after the 80, it's female predominantly. 50% 5-year mortality is very significant, and it's malignant as cancer. Female more than the male in terms of increasing number of cases and symptoms. There are countries who have managed to reduce this burden, annual burden. Those are countries like Israel and USA, 3.4% reduction in there because of lifestyle change and the risk factor control. So optimization of therapy due to device therapy, the GDMT, together the 5 pillars, they have improved the survival. There is a plateau phase in which the patient's quality of life is a little better. The goals during admission and comprehensive discharge planning is something which needs to be spoken at detail, so that I'm going to cover. Increase in healthy lifestyle, good exercise and diet goes without saying that they are the best if we do that. So there are 4 stages clinically, clinical perspective. stage A, B, C, and D. What is stage A is a risk of developing heart failure. It's divided into two. It can be in anybody, or it can be in patients with the structural heart disease, or some risk factors are there. Stage B is patient has had the previous symptoms or current symptoms, and one of the following is their structural heart disease evidence increase in filling pressure, and risk factors like BNP is increased, persistently elevated troponin. All these contribute to diagnosis of heart failure, even pre-heart failure. So stage C is something very important. It has a trajectory that I am going to cover. That low EF, that is less than 40%, is called as reduced heart failure or reduced EF heart failure, LVEF, FLAP. So all those things have been covered in greater detail, and there are another class, that heart failure with improved EF. That is the EF which improves from 40% with the GDMT to a better EF. Then the stage comes of mildly reduced EF, where EF is between 41 to 49%, and that is where it has a difference in the treatment chart. And preserved ejection fraction is totally different, though incidence is same, but treatment-wise hardly any option, but a medical treatment. Now, stage A, how to prevent that is the most important, because there are no symptoms, only they have some risk factors. So control all the risk factor, blood control, BP, diabetes, everything, and use SGLT2 if patient is diabetic for prevention of heart failure. This is a very important understanding about, and it's a multidisciplinary approach. Genetic testing is required to validate it on all the relatives, and BNP and validated multivariable risk score is also available for us to decide. Now, stage B, again, same, preventing the syndrome is very important. If LVEF is less than 40%, it's better to start this patient on S inhibitor to improve LV remodeling. The ARB is intolerant. If it is there, then we can convert into a certain kind of treatment, which is on the low dose. We have this available, smaller dose in India. Pharmacokinetic variations are plenty, and we need to consider smaller dose for many of our patients of many of medications. EF, even if it is less than 40%, beta blocker, selective beta blocker, in small dose do have a very positive impact. And some patient with low EF but no LVBB, that can be considered for ICD, that prolongs the life, because most of these patients have the VT from the scar, and that is something can be prevented by ICD, the sudden death. And then counseling is very important. So in stage A and B, it is more a preventive strategy, whereas in stage C, there is the trajectory, new onset de novo heart failure presenting as class C, then resolution of symptoms after the treatment has started. But after the treatment, if the heart failure persists or worsens, then we have to change our strategies and go on the device control or heart transplant or LVAD. The diagnosis is made basically on BNP and pro-BNP and echo. These are the two parameters, and that's where we look at the EF and decide whether it is preserved ejection fraction or reduced ejection fraction or mildly reduced ejection fraction, the three classes which are classically there. And then history and physical examination is of paramount importance for diagnosis. Chest X-ray, echo, and sometimes we have to consider higher investigation like cardiac CT, CMR, SPECT for evaluation of this patient. And if the patient has ischemic heart disease, best is to do angio and revascularize them if whatever the procedure is required, CABG or PCI. So if patient has a dyspnea, what is recommended is you do BNP and pro-BNP decide about the diagnosis, assess the risk of heart failure, and then, of course, it helps in hospitalized patient for diagnosis and treatment. So BNP becomes a very important parameter, but BNP can be elevated with some more conditions which are not relevant, like anemia, renal failure, severe pneumonia, obstructive sleep apnea, pulmonary. So you have to remember BNP in the light of all these diseases, if they are associated, should consider that possibility. Recommendation for patients with symptomatic stage C. So this is a very important stage because these patients are symptomatic. Here we consider in step 1 all the 5 pillars and see whether EF is reducing or patient is improving or not. Then we continue on GDMT. If the patient has persistent heart failure despite the optimal GDMT, then consider them for further treatment either with hydrolyzing nitrates, 1. Second, ICD, if there is no LVBB, only reduce EF. And CRTD, if there is reduced EF and LVBB. So consider all these in this patient, but if still in stage 5, if the still heart failure remains refractory, not responding to treatment, then those patients can be considered for LVAD and ultimately the heart transplant therapy. This is something which we have to understand, that those patients in stage D, they have class 3B and class 4 symptoms, and their quality of life is bedridden, or they are on IV anatropes, most of the time hospitalized. So recurrent hospitalization cost is very high. So in that respect, LVAD becomes relatively cost effective in prevention of recurrent heart failure, and quality of life improves significantly. Now coming to reduced heart failure, it's not the complete, that you don't start with ARNI, start with diuretic, then SGLT2, S inhibitor ARB can be considered, and if a patient can tolerate, we can give ARNI2, and of course diuretic MRA, and then evidence-based beta blocker therapy if required. So same is the preserved ejection fraction. Here we don't have any option but the medical treatment. And medical treatment again starts with the diuretic. That's the difference, that you don't start the entire 5 pillars simultaneously. We start with diuretic, see the response, add SGLT2, patient is diabetic particularly, and then consider ARNI, MRA, and ARB in that order. Now, when patient has a treatment option for C to D, as I said, that they have to be considered for LVAD, and adding hydrolyzin and nitrate do improve their, in addition to 5 pillar, improve their survival and symptom and quality of life. So there are several barriers in treatment option. The medical barriers, patient may go because of the quality of life is compromised, he is unable to do activity, he will develop depression, family will be affected. If he is a breadwinner for the family, there will be financial burden, social burden, and so many other personal barriers which have been absolutely very important for us. So we should have some social mechanism developed to control all aspects of the helping the patient, so that patient can be better in that respect. Then coming to value of the treatment, how do we assess the value? It is saying that though ARNI cost high, but if you don't add ARNI, their quality of life is bad. So it's otherwise they will have a recurrent hospitalization. So all the medical treatment 5 pillars have to be added. They have a great value, and then come to device therapy if they have persistent symptom, especially if they have LVEF, which is less than 35%, LVBB with QRS duration of 150 milliseconds, they do have problems. Now, in addition to the GDMT or 5 pillars, we have to also consider the additional therapies, which are ivabradine, which we all use in the practice, and they have 2A guideline recommendation. Vericiguat, which is a new drug, and it is being often used, and it's available in India, we are using it. 2B guideline suggests 2B. Digoxin, something which is forgotten for heart failure. If the patients are not improving on GDMT, do consider the digoxin. If patient has recurrent atrial fibrillation, paroxysmal, and going into recurrent heart failure due to paroxysmal atrial fibrillation, digoxin is very helpful that I observed in my practice, in addition to adding a Cardaron or separately Cardaron or digoxin, one of the two. Then in addition, there is a role for PUFA. Both can be given and they also improve the heart failure. Then potassium binder, because most these patients of heart failure on GDMT develop hyperkalemia. Fatty Romer is now available in India, and we can use that 8.4 gram in a powder form. The additional device therapies which are to be considered, one is a revascularization. Most important, look at the coronary anatomy. If suitable for revascularization, definitely consider either by PCI or CABG. Then optimization of drug therapy before we consider a secondary MR intervention due to with MitraClip, we should do consider certain factor. One is LV systolic diameter dimension should be less than 70 millimeter, and pulmonary artery systolic pressure should be less than 70 millimeter. And if they are still persist in that class, then they have to go for the additional like LVAD and heart transplant. Then monitoring pulmonary artery pressure devices are available, remote wireless monitoring, and that also helps reduce the recurrent admission rate but by 30%, but doesn't improve the outcome overall. So with this, we have come now to decide the CRT algorithm, when to consider CRT. This is a difficult decision because of the cost of the device is very high, and CRT-D most of these patients require. Most of these patients have LVBP, which is very significant contributor. What is important, even if patient has NYHA class 1 with 30%, less than 30% EF, and it may be ischemic cardiomyopathy, and LVBP more than 150 milliseconds, do consider them for CRT-D. Then class 2, NYHA class 2 to class 4, it's based on LVBP. Even they said non-LVBP can be also considered for CRT-D. The special consideration of CRT-D also comes for atrial fibrillation, RV pacing, frequent, and then of course the AV nodal ablation is important because one-to-one conduction should not be after we establish properly 6 weeks or 3 months of CRT-D placement. Then coming to the EF, which is 36 to 50%, and consider CRT-D if they have the complete heart block, 2A recommendation. So coming to mitral regurgitation, when do we consider? If the EF is more than 50%, we can send them for mitral valve replacement surgery. That is very effective. Or else consider the MitraClip for them. If they are not improving with JDMT treatment and MR is significant, you can reduce secondary MR, which is occurring due to the annular dilatation of mitral valve. So then coming to the recommendation for mildly reduced EF, again, diuretic, start with diuretic and then progress one by one, SGLT2, depending on the response. So adjunctive therapy, many patients in aged patient particularly, above the age of 65, 70, can have amyloidosis, make a proper diagnosis of amyloidosis and do genomic testing to find out whether they have the transthyretin cardiac amyloidosis or not. If it is transthyretin, then consider treatment with tafamidis. It's also available in India. So then atrial fibrillation, even if it is 2A, consider them for oral anticoagulation. That is very important because otherwise they can have a stroke due to thrombus in the LA or LA appendage. And individualized therapy is very important for every patient. There is a mnemonic for I need help for patients who have very sick intravenous inotrop. Their BP is maintained only on intravenous inotrop. They have a low BP, compromised main organs, the vital organs, kidney compromise. All these patients have recurrent admission in the hospital. They can be considered for I need help for all these parameters. Then most important thing, the salt and fluid restriction. 6 RCTs done, and they say there is hardly any benefit with salt and water restriction, which I found very surprising, because we all recommend for all our patients regularly restrict water intake, which is very relevant, because one side you are giving diuretic, other side you are allowing a full water. That's not correct. So assessment of the patient after all the GDMT has started, the goal of the therapy is improve the quality of the life, and of course precipitating factor, atrial fibrillation, acute coronary syndrome. So those 10 typical precipitating factor we have to keep in mind. And then decongestive therapy, especially the loop diuretic, I would like to mention that these when we use loop diuretic, they usually develop in large doses, they develop, and for a long time they develop increase in creatinine. But if you use infusion with a smaller dose, that also gives a large, even if you use 0.2 milligram or 2 milligram per hour, you can of any of the loop diuretic, then you can slowly give 48 milligram per day, and it will not increase the creatinine. That is for sure. That's one way of using loop diuretic in sick patient who require diuretic without any fall in blood pressure. Now, GDMT hospitalization, the GDMT is very important, whether admitted patient, inpatient, or pre-discharge patient. All need to continue GDMT despite they have a device or heart failure treatment or even after the LVAD. So all these patients require a care which is from the hospital to their home treatment, and that has to be communicated very well, all care to the patient. That becomes very, very important. In addition to optimized GDMT, we can have several other risk factors which have to be connected, but the most important thing is atrial fibrillation paroxysmal if you have, and you have placed the CRTD, then consider avinodal ablation for this patient. Though it is forgotten, but it's important that avinodal ablation, once the CRTD is properly established, after you think that 6 weeks, 3 months, then you can consider the avinodal ablation. The recommendation for managing comorbidities is very, very important, like hypertension, diabetes, and sleep disorder. Don't forget that. That is one of the reasons for causing frequent heart failure to the patient. So important to treat that. It's a very simple treatment by CPAP. Then you can do that treatment. So performance measure, we have to follow whether they are doing well or not. And goals of treatment is improve quality of life. So patient reported outcomes, this is very important. Apart from that, we should understand, has the patient improved symptomatically or not? This is very important. Then once you transfer to home care, there are certain factors which we need to communicate with the patient. Is individualized heart failure plan initiated, ongoing assessment of including remote patient monitoring through wearable devices and virtual visits, and care compliance and ongoing communication with clinician. This is a very important aspect post-care. If a pregnant lady or supposed to have a pregnancy, if she has a heart failure, then you can't give GDMT. That is a very important aspect because they can harm the fetus. So looking at the social barrier, if you made breadwinner or even if the earning is there, financial burden is huge. Food insecurity comes in because a lot of money goes in for care. Then housing is because people sell their property to have a treatment done. So there is a question of that. The unsafe environment for the heart failure, language barrier, patients may not understand, may not be able to communicate properly what he has been suffering from, and transportation issues for recurrent visit to the doctors. So online visit becomes very important. Then low health literacy and low social support is also very, very important. Now, there are certain research points. Still, this area is open for the research because several areas we have not properly understood, not properly managed so far, and some of them is cardiomyopathy definitions. We have to be clear on this. Looking at this, we should also do a screening, genomic screening for all the relatives. That becomes very important. Diagnosing and monitoring patient with the remote monitoring is of the paramount importance to understand that they don't have recurrent admissions in the hospital. Non-medical strategies like lifestyles change, particularly with the diet, is very important. Medical therapies that are effective should be considered, particularly guideline-based therapy becomes very important, but still a research area. GDMT may not respond, all the patient may not respond to alone GDMT, even currently. So timely selection of the patient for convergent of tachyarrhythmia with CRTD, that saves the sudden cardiac death and improves overall outcome. So we have to look at entire social determinant of health, the diet, exercise, sleep, and if they have several, and then comorbidities, most important is atrial fibrillation, associated structural heart disease, obesity and diabetes, both have become a pandemic throughout the globe and cause severe burden. So top 10 things that you should know, that GDMT should be given all throughout, at the hospitalization, pre-discharge, post-discharge, GDMT has to continue. SGLT2 definitely has to be there for all the patients, particularly if they are diabetic. And very, very important drug is like pleiotropic drug. It can be used in several occasions, on several things. Even non-diabetic patient we can use for control of heart failure. New recommendation for preserved ejection fraction, it starts with the SGLT2 only, and then consider rest of the pillars of the heart failure. Improved EF, if it is there, still continue the GDMT in the same doses, and you can optimize the treatment or titrate the treatment, reduce the treatment if the BP is not supporting. And many patients do not get proper control of BP because they have hypotension. So those patients we can reduce the dose, then value the treatment that we have to explain the value of the treatment to the patient so that he adheres, the compliance is good. Then amyloid disease, as I said, tafamidis is available these days for control of amyloid-related heart disease and control of heart failure. If the LVEF improves above 40%, we still continue to do the GDMT in proper doses, not to reduce GDMT. It's the most important message. Even when patient is in heart failure or discharge, he's doing better, quality of life is better, is at home, and compliance, to maintain the compliance, must have a regular communication with the patient. That is the key for giving a long life to the patient. And consider all the devices which are available, including CRTD, LVAD, all those devices are very, very important. Now, recommendations are provided for select patient with the heart failure if they have anemia, hypertension, where NT-proBNP may not be a reliable parameter to monitor. And in those patients, we definitely need additional monitoring support so that we get an idea about heart failure is improving or not improving. Now, there are 10 key messages in the treatment update that prolonged use of ARNI is associated with better prognosis, no doubt about that. ARNI can be used relatively safely even in patients with renal disease, significant renal disease. Early introduction of Evidence-based heart failure medication improves ejection fraction, reduce mortality, morbidity. ERNI is safe, effective treatment option for all patients with heart failure. Further, dose escalation of medical therapy or optimizing doses of all the GDMT medicine is very important if patient is not improving, according to, or if improving, reduce the dose. If not improving, increase the dose. Both sides the guideline have suggested. So there are several challenges, and challenges mainly are related to the understanding of patient to continue give compliance, full compliance to GDMT. These are the major challenges, and how to convince? The only way to convince is regularly communicate with the patient, develop some communication channel with the patient. So optimal solutions, what are the optimal solutions? The communication channel, real-time monitoring of the patient based on various wearable devices. The protocols has to change according to the profile of the patient. If he has some precipitating factor, look into it, treat properly. These are optimal solutions for patients who are not doing well with the GDMT. Now, AHA suggested go with the app so that they are on compliance or not. If their medicines are reduced, then they can upload their credit card and have a regular supply of medicine even when somebody is not available to bring the medicine for them. So many old people, this is disease of old people, many of them, they live alone. Nobody is there to help them. Those patients are very, very helpful for those patients to have an app and full control. Thank you very much for coming.